Our project or our guideline that we were looking at were pediatric vision screening exams, and this is really because good vision is really critical for a child's development in learning. Refractive errors, amblyopia, and strabismus are typically detected through vision screenings in primary care physician offices and in schools. But delays in detecting these diseases can have really serious consequences, and it can lead to vision loss in childhood, learning challenges, and social isolation, as well as serious complications and blinding conditions later in adulthood for progressive myopia. So regular vision screenings are recommended throughout childhood, but the different academies and associations have slightly different guidelines. So the American Academy of Ophthalmology, the American Academy of Pediatrics, the American Association for Pediatric Ophthalmology and Strabismus all have slightly different guidelines in terms of when screening should start and the optimal intervals between screenings. Vision screening methods are broadly categorized into two categories. There's photo screeners and autorefractors, or for instrument-based screening that allow children who are too young to read charts, optotype or acuity charts, or the actual optotype or acuity charts, such as Snellen, that older children can read in a pediatrician's office. So the United States Preventative Services Task Force analyzed the evidence for the efficacy of this vision screening, and the report found moderate benefit for children between 3 and 5, but had insufficient evidence for children under 3. So what we think, and I co-lead the Eye Care and Vision Research work group, and Gayatri, who is on the call as well, she leads the pediatric subgroup of this. And we're interested in this, and we have a couple different ideas. The first one is a network study that could be done right now, which would just characterize the current screening practices by age, region, et cetera, using procedure codes. There are 3 different CPT codes and that have been included in OMOP for vision screening. And this would just get a sense of where we are right now. Now, we expect that actually if we have access to the electronic health record and the more details there, the vision screening, we're going to find slightly different results because, number one, not all children have insurance and will be billed for these vision screenings, but also some insurance actually doesn't cover the vision screening, particularly for the younger children. So having access to actually what's recorded in the EHR in terms of what was done by for the vision screening would be really helpful and also in terms of the referral practices to see if those children actually wind up in a pediatric eye care setting. So, but of course, this requires additional support in additions to the CDM in order to study this and using EHR data as opposed to just CPT codes. And then if we did have more data available, we could actually get into studying the benefit of these screenings, particularly for these younger children. But we would need additions to the CDM that would cover the vision screening results, referrals, visual acuity, cycloplegic refraction, strabismus evaluation, stereopsis, and axial length. So we like this study because we think that there's work that can be done now, but also we like the fact that this guideline could be driving actual additions to the OMOP CDM.